Hello everyone and welcome to today's Facebook Live with GBMC Healthcare.
Today we're talking about prostate cancer.
Now let's welcome our guest, radiation oncologist and Vice Chair of Radiation Oncology at GBMC, Dr. Jeffrey Nooner.
Welcome, Dr. Jeffrey Nooner.
Thank you.
We want to hear from anyone who's watching, so please do not hesitate to ask any questions. We are live on Facebook, and so let's get it started. Let's talk about prostate cancer and the screening process.
Okay. So prostate cancer is a very common cancer. You know, each year now there's about 172,000 diagnoses of prostate cancer and about 28,000 deaths from prostate cancer. So it's a problem and fairly big one in the country, yet our screening programs have not been very good at detecting the patients that need treatment versus those that don't. So for a long time, we were screening men across the board starting at age 50 with PSAs, and our National Preventive Health Task Force came out and recommended against that completely. And then in the last iteration of their recommendations, they basically said, starting at age 50, you should have a discussion with your primary care physician, who by and large are the ones that do the screening, about the risks and benefits of screening. There have been 3 trials that have been completed on prostate cancer screening, and they have shown a reduction in prostate cancer death and also spread to the bones from prostate cancer. But those effects in a very large unselected population are small. And so, you know, what comes with screening may be the diagnosis of a cancer that's going to cause you a lot of anxiety, but is not going to do anything to you in this lifetime.
Interesting.
Or side effects of things done trying to get the diagnosis. For example, nationally, the rate of an infection from a prostate biopsy is about 1%, an infection that puts you in the hospital. So these things, when you're managing a population of patients, they all come into play in regards to how you manage them. There are populations that are probably more at risk. You know, we've known for a long time that African American males have a higher incidence of prostate cancer and suffer more death from prostate cancer. And in the past, you know, we often recommended screening starting at age 45 for that population, but even the analysis of the 3 prevention trials, you know, there weren't enough African American men in those trials to really make a definitive conclusion on what exactly should be done. There are definitely patients who have strong family histories of prostate cancer where, you know, 1 or more close relatives have suffered prostate cancer. Those men should be considered more strongly for screening. And then any relative, close relative that is, who's had early prostate cancer diagnosis or has died from prostate cancer should be considered.
Okay.
Finally, there's a group of men where there are these inherited predispositions to developing cancer. If that's something that's known within the family, those men should be considered for screening as well.
Okay, we have a question already from one of our
Great.
viewers, so we want to get right to that. This is from Deja. Are there any financial or healthcare programs to assist low-income prostate cancer patients?
So that's a good question. I don't know if there are any directly for prostate cancer or low-income prostate cancer patients, but in general, there are programs to assist with financial matters when, you know, you're starting to engage with the healthcare system, and you know, that's more the realm of social work, not something I get involved with. But typically, if someone comes in and they don't have insurance, we work very quickly to try and get them on medical assistance, et cetera.
Make sure they're taken care of.
Yeah, I mean, we don't turn people away who can't get, you know, don't have the means to pay for treatment.
Right.
Okay.
So in talking about the screening, are there
Yes.
reasons, maybe kind of tell people what the screening does entail or reasons that people don't get it?
Sure. So, when it comes to why people don't get it, meaning they shy away from addressing it, I think the nervousness about having a digital rectal exam by your doctor turns off a lot of men. I think the anxiety around possibly finding something turns off a lot of men. So those are the two big reasons I think that drive men from going to the doctor to get screening done, especially if they have. I mean, it's paradoxical in that some men who have a strong family history often will avoid it the most, right? Because they're afraid of finding something. And the problem is those are the ones who are most likely to help through a screening program.
Right.
So when it comes to the screening itself, do you start at your primary care doctor and you just start the conversation is what you're saying?
That's right.
Okay.
That's right. So there's no like set program, you're 50, you get a PSA and a rectal exam. It's really, we can embark on this together and, it may lead you down this path or that path. The screening in general is thought to be appropriate for men 50 to 69 per our national preventive health task force. So 70 and over, they're not recommending routine PSA screening for anyone.
Wow.
We have a couple more questions. Let's see. First one is from Melissa. How can people find out about support groups or other support programs for prostate cancer patients?
So that's a great question. If you go to GBMC's website, we'll have information there. Also, Chesapeake Urology, who I work for as well, they have information on their website for patients that have gone through prostate cancer treatment. One center we work with pretty closely is Hopewell Cancer Center. They often have programs for patients who have, suffered side effects, both emotional and physical, from treatment. There are national organizations. Zero Prostate is one, and in fact, they'll be holding a charity race this Sunday in Towson.
Oh, that's great.
Which is a Zero Prostate. Actually, I should say the Sanford Siegel Zero Prostate Cancer Run, which is a great event, and I encourage everyone to come out and participate. But Zero Prostate also has information on support for patients.
That's great. And we actually have another question from I believe this is James. James asks, what does PSA stand for?
Prostate-specific antigen. So on the surface of cells, there are proteins, fats, carbohydrates, and certain cells in the body make certain proteins, fats, carbohydrates, and those are, the prostate has an antigen that is specific for it. It's one of the most significant things that was ever found. But again, as we talked about, PSA is not necessarily specific for cancer, it's specific for prostate. So, as you get older, your PSA, a normal PSA kind of goes out of the box to some degree. A lot of men will have higher PSAs, and that just may be related to an enlarged prostate, which is something that's common and found in older men.
Okay.
Okay, so let's say that somebody walks into your office, right? Now they have prostate cancer. What happens from there?
So if someone walks in with prostate cancer, the first thing we do is stage them, right? So to get a prostate cancer diagnosis, you do a biopsy. And there'll be information from the biopsy which is useful in staging. And the three components of staging besides imaging are the PSA, the digital rectal exam, so if you can feel cancer and how extensive is that, and then how the cells look under the microscope, which is called, historically it was called the Gleason score, but now actually we go on a WHO grading system, World Health Organization.
Okay.
But a lot of people hear Gleason score. So we take those three things and we stage the cancer. If necessary, we do imaging to look for any spread of disease. Once that the cancer is spread, then we can have a counseling session with the patient regarding the options for treatment or no treatment.
Okay, so treatment with prostate cancer can be a little bit, it's very individualized, is what you're saying, and it can be a little bit, it's different than other treatments for other cancers.
Yeah, I mean, it's very much dependent on the stage, and then also the side effect profiles of the individual treatments, which we can go into, and then also, you know, other factors like the patient's urinary function.
Okay.
Whether or not they had radiation before, do they have autoimmune disease, or all these other things that play into how we counsel patients.
Okay.
In general, you know, we have low, intermediate, and high risk, and then intermediate sort of in the last 2 years been broken up into low and or favorable and unfavorable intermediate.
I see.
So 10 years ago, if you had low risk cancer, you by and large were getting treated. Now, in our practice, probably 80 to 85% of men with low risk cancers are being put on active surveillance paradigms where they are not treated, but they're followed with PSAs, digital rectal exams once a year, and then biopsies every 1 to 3 years.
Okay. And I do believe we have another question from social media.
Sure.
Let's see. James asks, who is at risk for prostate cancer? That's a very good question.
So prostate cancer is pretty common. If you're a male in the United States, the statistics are that 11%, you have an 11% chance of developing prostate cancer in your lifetime. Okay?
Wow.
So it is very common. I think the more salient question is who is at risk from developing a prostate cancer that is going to affect them either by spread to the bones or death. You know, so aggressive prostate cancer. And again, some of that can be, some of that risk can be determined by, you know, family history, if there are men in the family that have had those sorts of prostate cancers, or if there's a genetic predisposition. But we don't yet have great screening tools to try and figure that out.
Right.
The one thing that's come online in a lot of patients that have low risk or favorable intermediate risk cancers get is a genetic test of the cancer itself to try and determine, you know, how aggressive that cancer might be. So what we try and do with that is take the patient's cancer and take the genetic expression, study the genetic expression of that cancer, and try and marry it up with the genetic expression of the cancers of men where we know what happened to them.
Okay.
And so, you know, if we see that someone has a, you know, an expression, genetic expression in their cancer that's similar to a man who died very quickly of their cancer, even if they're in the low risk group, we might say, hey, you know, this kind of makes us want to treat you. Unfortunately, we don't yet have data showing that using these types of tests makes a difference in a population of men that we're managing.
Right.
So, you know, that's something that we'll probably find out 10 to 15 years in the future.
So when do patients typically encounter problems if they do have a prostate cancer?
So this is the other, you know, sort of the psychological impact of prostate cancer diagnosis. Most men have no symptoms at the time of diagnosis, and most men won't have any symptoms from their prostate cancer for 10 to 20 years.
Wow.
And, you know, this is very different from the old days where men might come in with urinary obstruction from their prostate cancer, or blood in their urine, sometimes even rectal obstruction. In the worst case, spread to the bones, causing bone pain. You know, what we see in our practice, I think, is that it's very hard for someone to get a diagnosis of cancer when they feel totally fine.
Yeah.
That,
You mean emotionally difficult?
yeah,
Yeah.
yeah. I mean, it's very hard to square that there might be something wrong with them when they feel totally fine.
Absolutely.
But this is kind of what screening programs do. They find things before they become a problem.
Preventative care.
That's right.
Yeah, and it's so important. And you think, so what I'm getting from what you're saying is starting the conversation with your general care practitioner is the biggest thing that you can do, whether you're 50 or not, or whether you feel anything or not, just
That's
starting the conversation.
That's right. That's right.
Okay, wonderful. I think we have another question on
Yep.
social media. James asks, if you have prostate cancer, should you continue to get checked out?
Yes. I don't know if this relates to being treated and then, you know, after treatment, or if the diagnosis was made and you don't do anything afterwards. So, but we can take both of those situations. If you've been treated for prostate cancer, you should definitely continue to undergo surveillance for any recurrence of the disease. And that typically, because prostate cancer has such a long natural history, we will follow men out 15 years
Okay.
to determine whether or not there's going to be a recurrence. There are certain groups of men where we have national guidelines for managing all cancers. They're called the National Comprehensive Cancer Network Guidelines.
Okay.
If you make a diagnosis of a low-risk prostate cancer in a man who has less than a 10-year life expectancy, those guidelines, even as hard as this may be for a lot of people, those guidelines say you do not have to do anything else, not
Wow.
even surveillance. Now, how do you determine someone's life expectancy?
Right.
So most of us use Social Security, so you can actually estimate your life expectancy because you need to know how much money you need in retirement. But you know, it becomes tricky because some people have very good health even at age 80, and so their Social Security predicted life expectancy may not be accurate. And so you can add or subtract from it based on other medical problems the patient may or may not have. But in general, there is a group of men where you could probably do nothing after a diagnosis is made of prostate cancer, but you really need to talk to someone who's an expert
Yeah.
and not make that decision yourself.
Okay, we have one more question. This one is from Deja. Can you go over the signs of prostate cancer? So I know you said that there's,
Thank
you know, usually by the time you see the symptoms, it's pretty advanced, right? But what are things that people should look for?
So for patients that present with symptomatic prostate cancers, urinary obstruction, so they can't get their urine out, but that by and large is rarely due to prostate cancer in this day and age. Usually it's due to just an obstructing large benign prostate. Blood in the urine, obstruction of the rectum, so having a hard time having a bowel movement, and then, you know, in the very advanced cases, bone pain from spread to the bones.
Oh, wow.
But that's also very rare that we see people coming in with
That advanced of a stage.
right.
Okay. We have a question from Courtney. Courtney asks, is it too early to start getting screened for prostate cancer?
Too early at
Is it ever
Oh.
too early? Like,
yeah, so the national guidelines recommend starting at age 50. Excuse me. There's, you know, in the past there have been some recommendations for African American men to start at age 45, but those are not at all like written in stone. I think that's very much dependent on if there is a strong family history in that particular male's family.
Well, what if there's a family history of cancer, but maybe not prostate cancer? Does that still raise their risk?
Not necessarily.
Okay.
So it depends on what kind of cancers they were, whether or not we can peg those diagnoses to an inherited predisposition to developing cancer. And truth be told, we're sort of in the dark ages of all this right now. I mean, we get a lot of patients who come in who have strong family histories of cancer development. So we think something's going on, but we send them for a genetic test and we don't find anything. But that's often because there are mutations that we see and we just haven't correlated them in enough patients to cancer development to say, oh, this mutation is responsible or is contributing to cancer development. It should be always kept in mind, though, that most cancer is sporadic, and it's the result of just a combination of factors and bad luck.
Okay.
All right, we have another question. This one is coming from Douglas. He says, how can you improve the incontinence after surgery?
So I wish I could address that because I'm a surgeon, but I'm not a surgeon, and I don't do prostate cancer surgery. It is one of the most one of the side effects of surgery that affects quality of life most, and so it is very important to consider it. But I think I have to defer that to a surgeon.
To the individual surgeon that you're seeing.
I mean, typically if someone has everyone has incontinence usually after a prostatectomy, which means removal of the prostate. And then most men recover their continence sometime between 2 and 6 months.
Okay.
It can take longer in some men. There are exercises you can do at home. So, the most famous set of exercises are Kegel exercises. But there's also formal physical therapy that can be done for incontinence. There's also, there are, if the incontinence is due to an overactive bladder, there are things that can be done for that. So it's very much dependent on why the incontinence is happening, what's the underlying physiological reason for it, as to how the interventions are given.
Okay. And we have 2 more questions from social media.
Keep
them coming. This is good. Deja asks, what's the average age of diagnosis? I'm thinking she means of the people who are getting diagnosed. Is there an average age?
So I don't know this off the top of my head, but I would assume it's 65 to 70.
Okay.
Okay. And we have another question, I believe. What age should we start educating young men about prostate cancer?
That's an interesting question. I'm not sure you need to educate young men about prostate cancer unless there is a very strong family history and you think that enhanced screening is going to be needed in the future. And really it's more to just key them in that, look, when you turn 45, maybe you want to talk to your doctor about it because, your uncle, your father, another uncle all died of prostate cancer, or they had prostate cancer very early. And so, it really, I think it's not something you talk to generally to young men because it's not an issue in that way. But in a family with a very strong family history of prostate cancer where enhanced screening screening is going to be necessary or desired, maybe you talk to them in that situation.
Okay, so let's talk about prognosis and diagnosis and everything. So let's say that you have prostate cancer, right? And then we get rid of it. And then how do you manage it if it happens to come back?
So it depends on how it comes back.
Okay.
So typically after treatment, you're followed with PSAs, okay? So after surgery, your PSA should be 0.
Okay. And that's a blood test?
Yes.
Okay.
It's a blood test. After so after surgery, the PSA should be 0.
Okay.
After radiation, it should be low and not rising.
Okay.
So, you know, radiation's a little bit more nuanced because the PSA usually doesn't go to zero. Usually it stays at some low level. And in the years, you know, 3 to 5 years after treatment, you can actually get what's called a bounce. So the PSA might come up a little bit and then go back down. So you have to kind of follow it. We now consider a failure of therapy of radiation therapy, that is, as an absolute rise in the PSA of 2. So, but we can talk about it from either way. If we think that there's what we call biochemical failure, which means the PSA is rising, then we try and figure out why. Is it from cancer recurring in the prostate bed if the patient had surgery? Or is it from cancer recurring in the prostate if they had radiation? Or is it from cancer recurring in the lymph nodes, which can happen either way? Or is it from distant spread of disease? And you know, the way we look for those things is with imaging. You know, sometimes if they had radiation or surgery before, and there could be a nodule recurring in the prostate or prostate bed. And once we, you know, if we find something, then it depends on where it is. So if it's in the prostate after radiation, the options are maybe to do a different form of radiation, or to freeze the prostate, or to do a high intensity focus ultrasound of that nodule. There are doctors who will do prostatectomy after radiation, though the severe complication rate is higher, and so you know, a lot of doctors are loath to do that. If there's a PSA recurrence after surgery, then you know, we by and large use radiation in that setting in what's called a salvage treatment.
Okay. Well, this has been super informative. Thank you so much.
Oh, you're welcome.
We're super glad to hear from you. And just to reiterate everything we've kind of said today, not everything, but you're recommending that people start the conversation with their primary care physician.
Yes.
They talk about getting screened after 50. And it seems like most importantly that they look into their family history to see where they stand at risk for prostate cancer.
Yeah, I think that's one of the big things that will influence screening potentially, having a family history.
Wonderful. Thank you so much.
You're welcome.
Thank you. All the
You're welcome.
information for everything that we talked about. If you want more about Dr. Nooner or getting treated at GBMC, right there on the bottom of our screen. Thank you so very
welcome.
much. And thank all of you for your great questions today.